Uh, Welcome everybody to today's session. So today is webinar number 147 on our platform Young India Intensive Sunday Critical Care webinars. And we've done previous sessions also on ventilation, which are available on our YouTube channel. So today's session is going to be taken by Dr. Anup Kumar. So Dr. Anup Kumar is director of Astral Cluster Group in Kerala, of obviously critical care services. So we look forward to this session, and I hope all of you enjoy the session. If there are any questions, we will take them in the end. So over to you, Dr. Anup Kumar, sir.
Yeah, thank you so much for this opportunity. And really sorry, there is some issue with my video. Uh, but without video, I'll be sharing my PPT, and your doubts you can share in the chat box, or later we'll discuss that. So, as you all are aware, ventilation is a very vast topic. It will be very difficult for us to like explain all the concepts about ventilation in one session. So today we'll be concentrating on basic modes of ventilation, where we'll be discussing the different modes of ventilation. Maybe in a later session, we can have discussions on different case scenarios. Like as you are aware, we'll be ventilating mainly three types of patients. One may be with a normal lung. We may be intubating them for non-pulmonary reasons, like they may be having a decreased sensorium or muscle weakness, etc. So that is one group of patients. And the second group will be like an ARDS type of lung, where the lung compliance will be poor and the patient will be having oxygenation issues. So our main strategy will be to keep tidal volume low, keeping the driving pressure somewhere around 15. And then we will have to maintain adequate oxygenation. And the third will be a patient with a obstructive airway disease or something like a COPD asthma. So there our peak pressures will be high, and our target will be to avoid auto peeping and to maintain minimum oxygenation. So we'll be discussing those scenarios along with the modes also, but we will not be going through the troubleshooting, the alarm setting, or other detailed the physiology or the basic physiology, the respiratory physiology, etc. We will not cover. So we'll be basically covering the modes of ventilation today. So, as you all are aware, the invasive ventilation is basically the delivering the positive the pressure to the lungs via an endotracheal tube or a tracheostomy tube. So, we'll be pushing air into the lungs using a machine, and we'll be regulating different pressures and the mode of delivery of air using different settings. So there are physiological objectives and the clinical objectives in the mechanical ventilation that you should be well aware. So the main physiological objective, as you are as you all know, are to support the pulmonary gas exchange based on alveolar ventilation and arterial oxygenation. And the second will be reduce the metabolic cost of breathing by unloading the ventilatory muscles that may be having a role when the patient is in a severe shock, and minimize ventilator-induced lung injury. So all these physiological objectives we should try to satisfy during ventilation. The clinical objectives will be, we will have to reverse hypoxemia, we will have to reverse acute respiratory acidosis, which I've already told, maybe in a type 2 respiratory failure, relieve respiratory distress, whatever may be the cause, then the prevent or reverse the atelectasis. That may be a situation in a post-operative patient or in a trauma patient. Reverse ventilatory muscle fatigue, that the permit sedation and neuromuscular blockade. So in some particular situation, decrease systemic or myocardial oxygen consumption in a severe septic shock patient, stabilize the chest wall, maybe a patient with a flail chest, etc. And airway protection, as I've already told during the initial slide, that when the patient is having decreased sensorium. So the mode basically refers to the method of inspiratory support, how we are going to deliver. So it's basically in the inspiratory part. And a set of operating characteristics that control how the ventilator functions. And a specific combination of breathing pattern, control, and operational algorithms are used to have different modes of ventilation. And as you are aware, we have many modes of ventilation. The newer modes of ventilations are also there. But in this class, we will be covering the basic modes only. So coming to the control variables within the breaths. So this is a basic concept as far as the modes are concerned. So what cycles inspiration to expiration? So that we will have to control. Then who triggers inspiration? Whether it is a patient triggered breath or it is a machine triggered breath, and what limits inspiration, at what point of time the inspiration is getting limited. So I'll repeat again: what cycles the inspiration to expiration, what limits inspiration, and who triggers inspiration. So these are the main control variables within a breath. So this, as you can see, there is a initial inspiratory phase, then the inspiration ends, then the patient is going to an expiratory phase. Okay, then the gas flow reaches the baseline. So this is the basic respiratory cycle. There is an inspiratory cycle and an expiration. And in the first part, who triggers the inspiration? I've told. So it can be either a patient triggered breath, especially when the patient is spontaneously breathing, or it can be a machine triggered breath. So here you should be very clear about one concept. Like we are having basically three types of modes. One is a control mode, second is an assist control mode, and third is a spontaneous mode. So in a control mode, the patient is not allowed to take any breath and the machine only delivers the breath. So that is called the control mode. So there is no synchrony between the machine and the patient. So for that, the patient should be completely paralyzed and patient should be completely sedated as well. So each breath will be delivered by the ventilator. So what you have to understand very clearly is the present day ventilators, especially present day ICU ventilators, are not having control mode at all. All the modes what we are using, whether it is a volume control mode, VCV, PCV, or like any other types of newer modes, all these things are assist control modes. So if the patient is breathing, the machine will trigger according to the patient effort, or the patient effort will be synchronized with the machine delivery. If the patient is not at all breathing, then the machine will give the breath. So that is the assist control mode. So all the ICU ventilators are having only assist control mode and there is no control mode. Okay. So that is about the triggering the inspiration. Then what limits the inspiration? At what level the inspiration is getting limited? So here again, you are having two options. One is either it is a volume control or a pressure control. In a volume control ventilation, so this is the graph is for the pressure control ventilation. In a volume control ventilation, once the airflow reaches the target volume level, the inspiration limit at that point. Suppose if you keep a tidal volume of 400, at 400 ml of tidal volume, the inspiration will be limited. So that is the volume control. Or in other words, the volume is kept as constant in volume control mode, and the pressure will be varying depending on the airway pressure or the lung compliance. Okay, so the pressure is varying, but the volume is constant, or the volume limits the inspiration. Whereas in a pressure controlled breath, like suppose if you want at 20 pressure control, you keep it as a 20 pressure control, but the volume depends on the lung compliance. So that is varying. So it is a volume limited breath, okay, or volume controlled breath. So that is how it is getting limited. Then what cycles inspiration to expiration? So there is a inspiration and expiration is divided into like like inspiratory expiratory ratio. On a normal default settings, we keep it 1:2. But for a patient with a severe hypoxemia or an ARDS ventilation, we always go for something like 1:1 if the patient is really hypoxemic. But less than 1:1 or the reverse, inverse ratio ventilation, usually we will not practice in adult ventilation. And the expiratory time is kept more when there is a auto peeping or when you are ventilating a COPD patient or in an obstructive airway disease. Okay, so that is about cycling the inspiration to expiration. But if it is a non-invasive ventilator, we are having again other options like inspiratory time or like the minimum inspiratory time, maximum inspiratory time, or expiratory cycling, etc. That is a different thing which we'll discuss later. So coming to the time trigger. So the trigger initiation of inspiratory flow from the ventilator, like suppose I keep a respiratory rate of 10. So every 6 minutes, the ventilator will be delivering the breath. So that is a time triggered breath, or it is a time initiation of inspiratory flow from the ventilator. Okay. So when we have a pressure, then again we have the pressure trigger and a flow trigger. So in the pressure trigger, as you can see here, when the pressure like goes to the negative value to a particular level, suppose if you keep a -2 centimeters, then the machine will sense that as an inspiratory effort and machine will deliver the breath. Suppose if it is a volume trigger, again a particular volume, if it is something like 2 liters or something, if you are 2 liters per minute or something you are keeping, when it is reaching that point, then the patient is again will trigger the breath. So this is the pressure triggering. Here as you can see, here we have kept it, say 1 centimeters of water. So when the patient is reaching the 1 centimeters of water, that is a -1, then the breath will be triggered. Okay. So here also, what you have to understand is, if the patient is having a tachypnea, so you should not try to reduce the rate by increasing the pressure control. Oh, sorry, pressure triggering. The triggering, the value for the pressure triggering. I've seen many people doing that. If the patient is becoming tachypnic, you increase the pressure triggering value. Or otherwise, sometimes you will not look at what is the triggering value you have kept. So that also should not happen. You have to always see what is the triggering, whether it is a pressure triggering or fault triggering, both are equally good. So previously, it was thought that the volume triggering has some advantage, but now both are equally good. You can either go for pressure triggering or volume triggering. As a default value, we always go for two. What you have to understand is each patient effort should be sensed by the machine, and the inspiration should be delivered. The same way, a minor movement in the circuit, etc., should not be sensed by the machine, and it should not cause an auto triggering. So you have to avoid auto triggering. At the same time, we have to maintain the patient ventilator synchrony as well. So that is the main concept regarding the pressure triggering. So you keep it for the practical purpose. You keep it at 2. See, all the efforts are getting triggered. At the same time, there is no auto triggering. Okay. If there is any issues with that, then we will have to adjust the trigger setting based on that. Okay. So in assist control, I've already told, like here, the patient is effort is detected, and then the breath is delivered. And in control, only the machine on the particular time interval, the machine will give the breath, and there is nothing like a trigger setting. So one simple useful tool here is, any mode with a trigger setting will be always a spontaneous or an assist control mode. A pure control mode will not be having a trigger setting. Okay, so any modes if you see in your ventilator, if it is having a trigger setting, that is always an assist control mode or a spontaneous mode. It can't be a control mode. Or if it is a control mode, it will not be having a trigger setting. Some of the anesthesia bellow ventilators may be using this control mode, but others I've already told nothing like that. Okay. So now coming to the flow triggering. So there is as you can see, there is an expiratory flow transducer. So, and there is an inspiratory limb. The patient, the air goes to the inspiration, then it returns through the expiration. And in a base flow will be somewhere around 2 liters, and you will be having something like trigger flow also. So when the patient begins inspiration, flow is taken from the base flow. The reduction in base flow is sensed by the expiratory flow transducer. Okay. So here it is basically the reduction in the basic flow is sensed. And when the base flow is reduced by the trigger flow amount going to the patient, the ventilator initiate the breaths. So here you have a you have a basic baseline flow. From the baseline flow, the patient is taking the breath. So the baseline flow will be reduced. So how much reduction in the flow is happening? That is the machine will sense that. So that is what is the flow triggered. And the cycling, which I've already explained, it can be like it can be time cycled, and it can be like volume limited, or the or it can be volume cycled or flow cycled also. This is regarding the cycling. So here, the when the inspiration ended, and then allowing the expiration to start. Here you can see the inspiration ends, then the expiration is starting. It is basically time cycle. So when it is it is a pressure controlled also, a particular pressure is reached, then the machine will stop the inspiration. Same with the that is again the ventilator control. Then in a flow cycling, a dip in flow it is sensed. That is something like an expiratory cycling, and that is again patient control. And we have a volume cycle, which is volume control. And in a pressure support, only in a spontaneous mode only, we will be having this flow cycling. Then we have different types of breath depending upon the three questions. So when like it is controlled, it is triggered, limited, and cycled by the ventilator, which I've already told. An assisted or assist control, which is triggered by the patient, but limited and cycled by the ventilator. But again, it can be a machine triggered if the patient is not triggering, which I've already explained. Then the supported or a spontaneous breath, which is always triggered by the patient, but the limited by the ventilator and cycled by the patient. So this is very important. In a supported mode, it is always cycled by the patient. But in all other areas, it is cycled by the ventilator. That concept also should be clear. Then we have a spontaneous, it is triggered, limited, and cycled by the patient, which there is no support at all. That is something like a CPAP. But supported will be CPAP with pressure support. Or in breath also, you can have a supported breath. So the breath type can be a control, assist control, either volume control or a pressure control, which I've already told, and something like a pressure support. These are the three breath type. In the control type, I've already told it is the volume control or a pressure control. In the pressure control, the upper part will be the flat, and this is this plateau. It is the plateau pressure. The pressure corresponding to this value is the plateau pressure. That is why you don't have to keep an inspiratory hold. Whenever you put a patient on a pressure control mode, whatever control you are keeping, that will be the plateau pressure. But in a volume control mode, I've already told that your volume will be constant, but the pressure will be varying. So here, when you have to keep an inspiratory pause or an inspiratory hold to know the plateau pressure. And it is pressure limited, then time cycled. But whereas in a spontaneous mode, the patient itself is triggering that, and there is a flow cycling happening there. Now coming to the basic modes which we are going to discuss, which I've already told, that will be the main discussion today. So we have volume control mode. It can be assist control or assist volume control, which I've already told. There is no pure control mode. Then pressure assist control. Then we have SIMV and the pressure support. These are the four basic modes which is available in our present day ventilators. So coming to the controlled mode of ventilation, I've already told it can be volume targeted, time triggered, flow limited, and flow cycle, volume cycle. So we are not going to discuss this one because we are not at all using the control mode. I've already told that. Now coming to the time triggered. In time triggered, like whenever you keep a particular rate, suppose something like a prescribed rate of 12. 12 means in a total minute, a 12 respiration will be delivered, and the prescribed time interval will be As you can see, it is 5 seconds. So every 5 seconds, one breath will be delivered. So that is the time triggered. Then other thing on the pressure tracing, which I've already told. So this is the inspiratory flow time. Then the peak pressure is reached. Then you have an inspiratory hold where the plateau pressure is reached. This is the volume control mode. Okay. Then this is the resistive pressure, the difference between peak pressure and the plateau pressure that corresponds to the airway pressures. And this is the plateau pressure, or which is corresponds to the alveolar pressure, and this is called as the elastic pressure, and this is also called the trans airway pressure. So if the patient is having a severe obstruction, this trans airway pressure will be high, but your plateau will be normal. But in an ARDS patient, your plateau will be more or your compliance will be poor. So whenever your compliance is poor, your plateau will be high. Whenever your airway pressures are high or whenever there is a resistance, peak pressures will be more. And the difference between the plateau pressure and the peak what you are keeping, that is called as the driving pressure, which we are always trying to keep it somewhere around 15. Okay, so we have driving pressure, plateau pressure, and the peak pressures. And there is an inspiratory time, and this is here we have an inspiratory time, and there is an expiratory time. And so here the inspiratory time is having again an inspiratory flow time, and an inspiratory flow, and an expiratory flow time, and sometimes an expiratory pause also. This expiratory pause or expiratory hold is used to assess the mode, to assess the basically the auto peep. Okay, so auto peep is assessed using the expiratory hold, and plateau pressure is assessed using the inspiratory hold. Now, coming to the difference happening with the pressures. So in the normal, we have peak inspiratory pressure followed by the plateau pressure. Suppose if patient is having a high airway resistance, your plateau will be normal, but the trans airway pressure will be high, and your peak inspiratory pressure also will be high. Okay. So suppose if the patient is having an ARDS like picture where the compliance is poor, your peak inspiratory pressure will be high, but your plateau also will be high, and you will be having a poor lung compliance. So this is a low compliance. So this is regarding the control mode of ventilation, which we have already told. And there is something called an intermittent mandatory ventilation. This was introduced early in 1960s. It does not improve gas exchange, does not decrease the work of breathing. And we have the assist control mode, which I've already told, which is time triggered and patient triggered control mode or assist control mode. Here we are setting the minimum breathing rate, the sensitivity level, and the type of breath. So the minimum level only is possible. Suppose if you are keeping a 15 breath, and if the patient is breathing at 10, the machine will give additional 5. But even if I keep a rate at 15, the patient can breathe at 20, 25, or whatever rate he or she wants. Although the patient can trigger the breath at a faster rate than the present mandatory rate, the set volume or pressure is delivered with each breath. So that is another beauty of this assist control mode. So the volume or pressure delivered with each breath will be at each breath will be the same as what we have set, depending on pressure control or volume control. Suppose I'm keeping at a volume of 400, even if the patient attempts are poor or the patient is not having enough respiratory effort, even then it is always 400 ml. But if it is an SIMV, each time the volume will be varying depending on the patient effort. Then the flow triggered one. Here the flow triggering usually occurs when the missing flow reaches some prescribed threshold value, which causes the ventilator to open the inspiratory valve and deliver the breath. So it is basically the drop in flow is sensed by the ventilator. Inspiratory valve opens, then the breath is delivered. So this is the flow triggered. Then the flow triggered breath, then again you can see this is the flow triggering here. So the work of breathing may be decreased, and it may be too sensitive, giving rise to auto triggering. So that is another problem. So we'll have to set based according to the patient effort. In pressure triggering, which I've already explained, the patient inhales against a closed inspiratory wall, producing a pressure drop by this effort, and in response, the ventilator delivers a mechanical breath by opening the inspiratory wall. So, when to open the inspiratory wall is sensed by the machine. So, we are fine tuning that using this pressure triggering or volume triggering, and again keeping the settings on that. Now, what are the advantages of spontaneous ventilation? So, in spontaneous ventilation, the patients will be more comfortable. It permits sedation to be reduced, so the patient can be awake. At the same time, we can keep the patient calm. It prevents dysynchrony due to unsatisfied respiratory drive, and it decreases the work of breathing and triggering, and increased control over ventilation is also possible. Better distribution of ventilation and better hemodynamic stability. So these are the advantage of spontaneous breath. Now coming to the SIMV or synchronized intermittent mandatory ventilation. So here in synchronized intermittent mandatory ventilation, again, you can see at a particular time, the machine will be delivering depending on the rate we are keeping. But this is also patient triggered. If the patient is having a respiratory effort, if the patient is not having adequate effort, the machine will deliver at that point of time. In between the controlled breath, the patient will be having the triggered breath. But depending on the patient effort, the volume will be varying. Sometimes the volume will be too low. So there we can support it with SIMV pressure support, where you can keep a pressure support level. But even if you keep a particular pressure support level, the volume will be varying. So that is the problem with SIMV. And again, why SIMV was introduced initially was, like, when this patient is having a spontaneous breath, in between, if you are giving a controlled breath, so initially it was thought that the patient will be getting the muscle rest, so the work of breathing will be reduced. But later on, when using the electromyogram in the diaphragmatic muscle, etc., it has been clearly shown that during this controlled breath, during a spontaneous respiration, so in between when you are giving the controlled breath, in fact, the work of breathing is increased or the muscle effort is more. So, for whatever concept the SIMV was introduced, that is giving muscle rest in between, that was not satisfied by the SIMV mode. That is why nowadays we are not at all using this SIMV mode. Now, SIMV with pressure support. I've already told this is the SIMV period, and in between we have the spontaneous period. So here the spontaneous period, it is a flow cycled respiration. The other one is a time cycle. So in the spontaneous breath, you can have a pressure support. Suppose if the patient is delivering a low tidal volume, we can give pressure support like in CPAP with pressure support. Then that volume will be increased. So it is again assisted in when you go coming with the pressure support ventilation or our common weaning mode. This is an assisted ventilatory mode. It is a patient triggered by pressure, airflow, or both, and it is pressure limited and flow cycle. And you cannot set respiratory rate, tidal volume, or I ratio here. Instead, we can change rise time and expiratory sensitivity to alter them. So this is very, very important. You cannot change the I ratio by keeping an I ratio or I ratio settings in a PSV mode or any NIV mode also. So here we are adjusting that by adjusting the rise time, expiratory sensitivity, or sometimes we'll be having a minimum inspiratory time and a maximum inspiratory time. So minimum inspiratory time is at that minimum value, the inspiratory flow will be kept, and after the minimum value, the patient can go to the expiratory phase. And TI max means, so it is the maximum limit the patient can hold the inspiration, beyond which patient cannot continue the inspiration, and it will be switched back to the expiration. So this is the pressure support ventilation. So usually how we does this, like initially we put the patient on a pressure control ventilation or a volume control ventilation. Suppose the main issue between these two modes are, suppose if the patients are having a a very increased resistance. So in a volume control mode, if you are not keeping the pressure limit on the alarm in the alarm setting, if the pressure limit on the higher side, the volume will be limited. Or if the patient is developing severe airway spasm, etc., the volume will be delivered, but the airway pressures will be shooting up too high. So the chances of barotrauma will be more. Suppose if it is a pressure controlled ventilation, the pressure is always controlled. But what is the danger in pressure control mode? If your nursing staff is not aware how to use that, the patient sometimes can go for a minor tube obstruction or an airway obstruction, and the pressures will shoot up, or the complex, or in other words, because of the obstruction, the trans airway pressure will increase, or in other words, because of pulmonary edema or something, if the compliance is reduced, then for a given pressure control, suppose if for a normal length, your 12 pressure control will be delivering somewhere around 12. Suppose if the patient is going for a severe bronchospasm. So at a 12, the patient may be delivering some 150 tidal volume alone. So there is always chance for hypoventilation in a pressure control mode if you are not constantly watching the delivered tidal volume. The same way, there is a chance for barotrauma in a volume control mode. So you have to constantly watch the pressures, like especially the peak pressures in a volume control mode. Okay, so that is the difference between those two. So here we have an inspiration and an expiration. I've already told. So this is the initial part. Then this is the P must. I'm not going to that. This is regarding the flow cycling. So here it is coming the 75%, 50%, at 25%. So at 25% of the peak flow, it is going into expiration. So the problems are inspiratory time is too long relative to the patient inspiratory time. And then the solution is if the VCV increase the inspiratory flow, in PCV decrease the inspiratory time. So these are the two things we can do in both modes. So this is how it is shifting from inspiration to expiration. The rise time is, again, you can see this is the slow rise. Then we have the moderate rise and a fast rise. So it is just increasing the flow rates, but it is called as a rise time. So even though it is called as the rise time, it is increases the flow rate. So this is the slower flow rate. This is the moderate flow rate. This is the very fast flow rate. So in the fast flow rate, you will be having a fast rise time. Okay. Or you have to keep the time on the lower value. Okay. So this is the T inspiration, T expiration here. This is again T expiration is increased, and here and again the fast rise, you will be having more expiration. So this is one settings by which you can adjust the expiratory time or IE ratio. So if you want more expiratory time, always go for a fast rise. If you want a more inspiratory time, always go for a slow rise. So this rise time, if you keep, that is also important. If you keep a rise time more, that means there is a slow rise. If you keep a rise time low, that means there is a fast rise. Don't get confused with that. Okay. So if you keep a very low, sorry, if you keep a very low rise time, then you can get a more expiratory time. The same way, if you keep a high rise time, then you will be getting more inspiratory time. So depending on the situation, suppose if if the patient you need more oxygenation, then you go for a slow rise option. And if it is a COPD patient, you need more expiratory flow or a more expiratory time, then you go for a fast rise option. Okay, this is the different modes. Now coming to the summarizing the topic. So we have the spontaneous ventilation. In the spontaneous ventilation, we have inspiration and expiration. So inspiratory part and an expiratory part. Then in an IMV, so sometimes you can have these air stackling, etc. These are the mandatory breath. So in between the spontaneous breath, sometimes the patient will give a machine will give a mandatory breath, and both will coincide, and that can have a ventilator patient asynchrony. That is why we are not using that. So this is the SIMV. So in between, the patient is having mandatory breath, but I've already told the mandatory breath was given to for the muscle resting, but that is not proven later. So this is SIMV and PEEP. So in between, you give a PEEP, and with the PEEP, you are giving more and more recruitment. So these are the different modes: CMV, AC, IMV, APRV, PSV, etc. So these are the target. In all the volume control mode, it is volume targeted. Pressure control mode, it is pressure targeted or limited. So it is in all the control mode, it is ventilator triggered. Or if it is a spontaneous mode or assist control mode, it can be either ventilator or a patient triggered. You can see here, it can be either ventilator or a patient triggered. The cycle or the breath termination can be in different modes, can be volume, time, etc. And type of breaths again can be mandatory, assisted, or spontaneous in different modes. Again, you can see in this assist control mode, you can have mandatory breath. It will be having assisted breath, and it will not be having spontaneous breath. It will be having only assisted breath. Okay, yeah. So these are the different modes. So we have discussed the different terminology. Sorry, those part we have not discussed. So these will be discussed in the different session. So today I think we have already crossed the time. Maybe in another session we can discuss all these things, like the setting of ventilator parameters, alarm settings, how to you set the PEEP, what is lung protective ventilation, baby lung concept, driving pressures, and advanced mode of ventilation. Okay, thank you for patient listening.
Thank you, Dr. Anup Kumar, sir. So nicely.
Thank you, thank you.
Yeah.
And really sorry, okay, actually I wanted to combine these two slides and wanted to do it tomorrow. So in my mind, it was somehow it was kept, it is tomorrow evening.
Oh, no problem. We'll have it again. Not a problem. We'll continue with the sessions. No, we'll have them again, whatever is remaining. No problem. So I will just, for the benefit of everybody, just add to whatever Dr. Arun Kumar sir has said. So first of all, all pressures that we talk about in the ventilator settings or the related to the ventilator are with respect to the atmosphere. So if you talk about a 5 centimeter of water pressure in the airway, that means 5 centimeter above atmospheric pressure of 760 centimeter of water. First point. Then second, the end expiratory pressure is all in the lungs is always zero in the spontaneously breathing patient. So there is no physiological PEEP, right? Some people think there is a physiological PEEP, the glottis closes and all that, but that is an old concept. It is not correct. Then that is because the end alveolar pressure at end expiration is zero. And why you set a PEEP of 5, which is called a physiological PEEP, is only because it is supposed to counter the atelectasis which occurs on the ventilator. And it is not because there's a normal physiology leads to a PEEP of 5. So that is a misconception and it should be clear. Then we talk about low PEEP and high PEEP, right? In the ARDS patients, there's something known as set a low PEEP and set a high PEEP. So what are low PEEP and high PEEP values? So low PEEP values are around 8 to 10 and high PEEP values are 10, 12 to 15. 12 to 15 is supposed to be high, 8 to 10 is supposed to be low or moderate. Then coming to mean airway pressures, what are mean airway pressures? So normal mean airway pressures are anything like 5 to 10, while in ARDS and in COPD you get higher airway pressures. In ARDS 20 to 30, in COPD 10 to 20 typically, but this can be variable depending on the severity of the disease. Now coming to P plat. So P plat is you give an inspiratory hold of 1 to 2 seconds and then you get the P plat. That is the plateau pressure, which he showed in the slide also. So the difference between plateau pressure and peak pressure is because of the loss of pressure due to friction in the airways when the air goes through the tubings. And you have to give an inspiratory hold to tease out this difference. The system has to be brought to a relaxation and this difference has to be brought out. That is why you have to give an inspiratory hold. And the other thing is the plateau pressure also is determined by something known as Pendeluft effect, Penduluft, and that is the airway, the air kind of redistributes amongst the alveoli as you give an inspiratory pause, and also because of stress relaxation, which is the relaxation of all the tubings. So the contribution or the determining factors for the P plat is one, the loss of the pressures due to frictional forces, and second, Pendeluft effect, and third, the stress relaxation. And what determines P plat? So there are three factors which determine plateau pressure. One, the total PEEP at the end of inspiration. Second, the compliance of the lungs. And third is the lung volume. These are the three factors which determine your P plateau. Lung volume means tidal volume. Now coming to stress and strain. So stress and strain are some basic terms, and we always hear that the stress is increased, strain is increased, and in ARDS, stress and strain are very important. So what is stress? So stress is the distending pressure in the lungs. Stress is the distending pressure in the lungs, and a value of anything greater than 25, 26 at end inspiration is considered detrimental. What is strain? So strain is the change in the lung volume over the resting volume, or the change in the alveoli lung volume over the resting volume, and it is given by a formula which is uh, PEEP volume plus the tidal volume over FRC. Okay, the volume that is added by giving PEEP plus the tidal volume over functional residual capacity, and its value should be less than 2. Okay, if greater than 2, it leads to injury to the alveolar, release of cytokines, barotrauma, etc. And the strain and stress are interrelated by a factor called the K factor, which is a constant factor. K is a constant factor for all the lungs, different in different species, and strain into 13 is equal to stress. Okay, and it should not exceed a value of 26. That is, if the strain is 2 multiplied by K factor 13, it leads to 26 of strain. So this is how stress and strain are interrelated also. And stress and strain are not the same throughout the lungs. They vary in different portions of the lungs because of different, kind of distribution of the inflammation, and because of stress raises in different parts of the lungs. Now coming to rise time. So Dr. Anup showed you some slides on the rise time. So what are the values for the rise time? So rise time is typically between 0 to 20% of the total breath cycle. And by default, it is set at 5% of rise time. And depending on the situation, you may alter the rise time depending on whether the patient is flow starved, or you want a longer expiratory time, shorter inspiratory time. That is how you may manipulate the rise time. And the typical values are 0 to 20% of the breath cycle. Default is normally at 5%. Now, the base flow, which he has shown you very nicely, also known as bias flow, BIAS, is main role is actually in flow trigger, like we showed it to you. Coming to other terminology, one is a function known as ATC, automatic tube compensation, which is available in many ventilators. So what is automatic tube compensation? So automatic tube compensation is actually something which was thought to help in weaning. You choose the automatic tube compensation mode, or whatever setting is there, ATC, and then you're supposed to enter the tracheostomy tube or tracheostomy diameter, whatever you have, and then it actually measures the pressure drop across the tracheostomy or the endotracheal tube, and provide support, pressure support, to overcome this resistance. So it's a kind of a pressure support which is provided, but sensed by the ventilator itself, and it's supposed to help in weaning. But people argue if you give a pressure support of anything like 5 to 7, it works in the same way. Now coming to another thing is, what is P.01? That is the P occlusion pressure. So this is the pressure drop in the initial 100th millisecond of an inspiratory breath, and it's a measure of the respiratory drive, and it's independent of muscle weakness. You see, you may think that if the patient becomes weak and all that, muscles become weak, is tired being on the ventilator for many days, the P.01 may vary, but the P.01 does not vary with muscle weakness. It is the strongest determinant of respiratory drive. And a value of greater than 4 seconds is high, a value of less than 2 seconds is low. Both are not good for weaning from ventilation. Typical values are 3 to 4 millisecond, 3 to 4 centimeter of water. So P.01 is a measure of respiratory drive. Now coming to cough reflex, we often talk that cough reflex should be good for weaning from the ventilator. But what is a good cough reflex? So there are no determinants of cough reflex on the standard ventilators. Cough reflex can be measured by negative inspiratory force or peak expiratory flow. A greater than -20 value of NIF or a greater than 75 of peak expiratory flow is considered compatible with a good cough reflex, but these values cannot be measured just standard, easily on the ventilator. You need additional equipment, etc. So all in all, at the end of the day, a good cough reflex becomes an objective phenomena. Now, other thing is about uh, the final thing I want to say is when you should do a ABG in the ventilator after changing the settings. You change the settings like PEEP, tidal volume, etc. So the ABG should be done at any time between 15 to 30 minutes. That much time it takes for the compliance to be reflected properly for the PO2, PCO2. But also remember that PO2 and PCO2 values can go on changing for some more time, even hours. The final values can take a little while, especially PCO2, because the PCO2 distributes across the whole body intracellularly also. So if you have to do a ABG, please remember it should be done 15 to 30 minutes after changing the settings, and also the compliance should be seen after 15 to 30 minutes after changing the event settings. In the case of ARDs especially, that is. And that is all I wanted to say. The final thing is about air distribution. You see, when you breathe spontaneously, how does the air distribute in the lungs? And if you push it in with the ventilator, how does it distribute? So when you breathe spontaneously, the maximum airflow goes to the regions near the dorsum of the lungs and also near the diaphragm. Because that is where you have the maximum negative pressure. And if you are delivering with the ventilator, it goes to the central areas of the lungs. So this has to do with positive pressure and negative pressure. When you breathe spontaneously, the pleura, there's a negative pleural pressure. So the maximum negative pleural pressure is near the diaphragm and near the pleura. So the air moves maximally to this region. But on the ventilator, the maximum air goes to the central areas. So these were a few things I wanted to discuss. I just wanted to highlight and share with you basics of ventilation is the topic. And these are very basic things. And I think most of you will find some of the things I said useful, and they are important, and one has to apply them when ventilating the patients. So Dr. Anup sir, you want to add anything?
Sorry, we have already discussed all other parts. So I think
what I have to say. You have anything to say?
no. It's like you have also added other record points. It's nice.
Yeah. Okay, then I think we shall close the session. I think further sessions Dr. Anup Kumar sir can take ahead in the coming sessions. So thank you, Dr. Anup sir. Thank you so much. I thank the audience for their patient hearing. And I think with that, we'll end the session. Thank you.
Thank you so much.